Hello everyone, it's Abdullah here, and today we're going to cover the pathology section of the MRCS, and it's a covering of multiple topics in the MRCS that I think are important to know as a surgeon. And yeah, I made it in sort of questions and answers because I feel this is an easier way to help you memorize things and also reach to the bottom of everything, basically. As you see here, this is the table of content, and the table of content I made it by topic wise, so starting by the related topics. So you will have some general pathology topics, which are like, for example, the abscess and the amyloidosis, as you can see here on the screen. However, the questions are added in the index as well. So you will sort of before the exam, I will probably need to go all these questions without having to read all the answers, just to make sure that I remember every single question of them. And let's say I am stuck at the definition of a fistula, I'll just click here and reach the definition very easily, and I'll be able to revise effectively and efficiently as well. All right. So I would advise you do something like that or something similar to this. And I'm happy to provide this PDF for anyone who's come to me and ask for it. All right, so like, can you see here we have the abscess and then amyloidosis and then the cell death and gangrene. As you see, the general theme for those three topics are your general pathology questions. All right, and then we go to sepsis, and then you're going to start for the GIT tract. Starting from the nasopharynx by nasopharyngeal carcinoma, moving forward by asbestosis, lung cancer, mesothelioma, tuberculosis, and these are respiratory tract, and then moving to adult respiratory distress syndrome, still in respiratory tract, and then you have the cardiac, like aortic stenosis, infective endocarditis, and so on and so forth, right? And I'll keep going like that, starting go to the gut parotid tumor. You have the peptic ulcer disease, and perforated peptic ulcer, and cancer esophagus, and all these questions basically will be covered on the coming series of the pathology. All right, so it's a very long index, but I felt that doing it like this will significantly help me in revising effectively and efficiently as well. So we're going to move down to start by the first topic, which is the abscess. And you have a few questions in the abscess, but before that, so basically an abscess is a localized collection of pus or localized suppurative inflammation or a cavity that has a pus inside it. So what happens in an abscess is, let's say this is a soft tissue, and there will be sort of a bacteria or a bug that come and invade this soft tissue, and it will lead to formation of dead tissue in there, and then surrounded by fibroblast. So this is what is called by an abscess. So an abscess is a cavity. The simple definition is a cavity containing pus. All right, the cavity containing pus. Okay, so that's the definition, and it's obviously a local inflammation. It's very important to mention that it is localized because the spreading inflammation will be a cellulitis rather than an abscess. So it's a focal collection of pus, which is formed by dead tissue, and we're going to come to what is pus now. So what's inside an abscess? So usually you have inside an abscess a central necrotic region, which contains the pus or the dead tissue. So the pus is usually formed of dead tissue and also dead cells as well, or dead bacteria. Okay, so it will have pus inside it or necrotic tissue, and also will be surrounded by a layer of neutrophils and polymorphonuclear leukocytes, and also dilated blood vessels and fibroblasts from the outside as well. Organisms causing an abscess, since we're talking about pus, so it needs to be most of the time as a pyogenic organism. And pyogenic commonest organism is a Staph aureus, and the second one is a Streptococcus pyogenes. But however, it can be caused by a non-bacterial source as well, like fungal and viral and parasitic as well. A simple test to do for any abscess that you're going to start draining it, you will take some samples and do a gram stain. And also, obviously, you will send it for culture and sensitivity as well. But as a simple test, you're going to do a gram stain. The cause of fever in an abscess. So in an abscess, so it's a local inflammation, but the inflammation releases some sort of acute phase reactant, and this includes tumor necrosis factor and also interleukin alpha 1 and 2. So both of those, the interleukin alpha and the tumor necrosis factor, will go just around the perivascular structure around the hypothalamus, which controls the body temperature. So it will go to the hypothalamus and will increase prostaglandin synthesis. which affect the vascular and perivascular cells of the hypothalamus and increase the body temperature. What is pus? It's a dead tissue, which is basically dead tissue and also dead organism and neutrophils around it. So basically, you will have, let's say, an organism went inside a tissue. So you will have the localized inflammation, the chemotaxis, and all these kind of things, which will come into it as well. It will lead to polymorphonuclear leukocytes will come in here, and also the neutrophils will come in here as well, and that will lead to eating of this bacteria and the surrounding tissue, causing localized inflammation. So this is basically what's pus. So we need to differentiate between a few things now. What is a fistula? What is a sinus? And also what is a stoma? All right. So a fistula is basically you have a patient who went to surgery and they have a wound in here and they're coming to you to your clinic with some sort of puncture at the end of the wound and there is some secretions coming out from it. So the key part in defining a fistula, it's a blind-ended. It's a blind-ended tube or blind-ended tract. All right. So blind-ended tract which is filled by granulation tissue. So blind-ended tract, which is filled by granulation tissue. So this is how to define a sinus. The next part is defining a fistula. So a fistula is not actually blind-ended, and that's the main difference. So it's a tract that connects. It's an epithelialized tract that connects between two different hollow organs. All right, or two different surfaces, basically. So that will be some sort of epithelial surface in there, and epithelial surface in there, and in between them, that's what is called biofistula. So, for example, you know the colovesical fistula, for example, which happens as a complication of the diverticular disease or diverticulitis. So colovesical is a fistula, so it's a tract that connects between the bladder and the colon. So this is what it means by a fistula. So abnormal communication between two epithelial surface or a tract that connects between two hollow organs or hollow viscus. Okay, and the commonest fistula is ear piercing as well as considered as a fistula and not a tract. But after some time, if you remove the earrings and we'll wait for a while, it will become some sort of like a sinus rather than a fistula because it will fill in with granulation tissue, but it might make a blind-ended tract. Moving forward, so yeah, this diagram again is really explaining it. So this is what is called by sinus. So it's a blind-ended, as you see in here, and is filled by granulation tissue in the wall. And you have here, this is a fistula, which is a communication between two hollow structures or two viscus, and it's a tract that's open from both sides and communicate between two epithelial surfaces. All right. What is a stoma? It's a surgical opening into a hollow viscus. That's a very simple definition. So it's a surgical opening into a hollow viscus. So basically, when you have, let's say this is the bowel and it was intact, and the patient coming with some sort of, let's say, obstruction in this area, and we're unable to operate in this patient for any reason. They say they have some sort of very unwell or things like that. So we can do something called fistula to relieve the obstruction. And the way we do that, we'll make a cut in here, and we'll take the proximal part, and then we'll bring it to the skin, just like that. So this is what is called fistula, and it can be classified into many reasons or many ways. So it can be classified into the anatomical site. Okay. So by the anatomical site, you can have a gastrostomy, that's a stoma, and you can have an ileostomy in the ileum. You can have a colostomy, and you can have a urostomy as well. So these are classified according to the site. Where is it? Okay. And the next point, you can also classify it according to the number of openings in it. So let's say we have a patient with, if this is the bowel, for example, this is the bowel, and we made a cut in there, and we brought the proximal part, just like that, to the skin. So that would be the skin on both sides. But I mean, it wouldn't exactly look like that. It would be some sort of like this. Okay. So now this one can have two lumens or two openings. All right. So this is called a loop stoma. And most of the time, it can be a loop colostomy or ileostomy, really. All right. So that's a loop stoma. And the one which I drew early, if you have like this one, that's an end stoma. because obviously the distal part will be just lying in there. So we define an abscess, and we know that an abscess is a cavity containing pus or a localized inflammation or an infection. But cellulitis is, on the other side, is a spreading bacterial infection that affect the skin and the subcutaneous tissue, and it's spreading. So, for example, a patient will be coming to you with redness and discoloration of and hotness as well of the whole lower limb. That could be a cellulitis rather than an abscess formation. As long as there is no localization of or accumulation of pus in certain area, that's cellulitis, right? So, how to differentiate between cellulitis and an abscess? As we said, the main definition is the localized, and the other one is diffuse or superficial spreading, inflammation or infection. Okay, the commonest organism for abscess is Staph aureus, but the commonest organism for cellulitis is Streptococci. And you have here localized necrosis or central area of necrosis in an abscess, and extensive superficial necrosis in cellulitis. There is an enzyme produced in abscess called coagulase enzyme. On the other side, it's something called fibrinolysis or hyaluronidase. All right. The abscess will form quite rapidly, and the cellulitis will take a bit time to form. So, in terms of treatment of an abscess, so it's always you always think, well, you have a patient with an abscess, will I drain it, or will I just give them antibiotic and wait and watch? So it really depends on the size of an abscess. So if you have some sort of localization, if the abscess is very localized in there, and you can see it accessible, you can just easily go and make a cut, drain it, and put some swab inside it and send some samples. And you can give your patient some antibiotic if you're worried. But the first one is incision and drainage of this abscess, which is usually the best treatment for an abscess. All right. However, on the other side, we can still give some antibiotic, but there is a very good rationale for incision and draining of this abscess, so that will clear the infection. If you remember when I explained the pathology of an abscess, there was some fibroblast on the outer area and polymorphin nuclear leukocyte that will prevent the antibiotic from reaching to the center of an abscess or the dead tissue. Okay, and if you left it without drainage, it might even complicate and start spreading to the deeper tissue. When to give antibiotics? So what if the abscess is not really localized or looks like cellulitis? That's the time that you will need to give antibiotic. Usually after we open an abscess or we do incision and drainage, we usually keep it open. We don't close it by any sutures or anything like that, because otherwise the infection will reaccumulate. So if you didn't do that, you will probably need to start your patient on antibiotic. What are the giant cells? Giant cells are multinucleated cells, which are derived from fusion of multiple cells. You have like a cell in here, another cell, another cell. They decided to coalesce together to form a big cell with 3 nuclei. So these are multiple nucleated cells, which is formed by fusion of multiple other cells. This basically happens in patients with tuberculosis and also leprosy and leishmaniasis, all right, and maybe sarcoidosis as well, and obviously Hodgkin lymphoma. Remember the Reed-Sternberg cells? That's one of the other examples. In TP, it's called giant cells of Langerhans. The commonest cause of granuloma, Mycobacterium tuberculosis, is the commonest. However, all of those can cause granuloma as well. It changes lymph node due to inflammation, something called reactive follicular hyperplasia, and it will be covered somewhere else. The causes of reactive follicular hyperplasia is basically inflamed lymph nodes are often enlarged anyway, and mainly due to hyperplasia of the lymphoid follicle inside it to increase the number of lymphocytes and macrophages. So we have discussed here what is an abscess, including its definition and its cause or causative organism, and also how to investigate, including the gram stain, and finally how to treat, which is one of two things, whether incision and drainage or given the antibiotic. And we need to know, we know how to give, when to give antibiotic now. If you didn't leave it open after incision and drainage, or the abscess is not localized. And we also discussed cellulitis, and we know that cellulitis is superficial spreading. So superficial spreading caused by group A beta hemolytic streptococci, and there is diffuse or extensive necrosis okay, and due to production of hyaluronidase enzyme as well. And this one is usually treated by antibiotic instead. We know how to define a sinus, and how to define a fistula, and how to define a stoma as well. So that was the main things that we discussed in the first topic. So yeah, we looked here, this is a reactive follicular hyperplasia. So if you look at this side is very organized and arranged. So this looks like reactive follicular hyperplasia. On the other side, it's haphazardly arranged. So this on the other side is malignancy rather than reactive follicular hyperplasia. And the mechanism is basically stimulation of beta cell component of the lymphoid follicle. This part will be covered somewhere else. Do not worry about it. And we're going to talk about it in detail. Well, next question is amyloidosis, which is sort of related to an abscess or chronic suppuration. I think the hallmark or the main question in amyloidosis, what is the type of the amyloid in patients with chronic suppuration or chronic inflammation, is something called amyloid-associated protein. We're going to come to this and discuss it in detail. But starting by defining an amyloid. What is an amyloid? So an amyloid is usually misfolded protein that deposit in the extracellular component. So if you have like a tissue which contains multiple cells, and these are the nuclei of each cell. So amyloid, it's a fibril protein and misfolded that join together in a haphazard way. So you will have multiple protein just on the outside of the cell, of each cell, that will join together and will be misfolded, all right? Just like that. So this is what is an amyloid on pathology or histology, okay? So this misfolded protein is formed mainly of two types, whether it's a glycoprotein or a fibrinoprotein. Fibrinoprotein represents around 95% of these, and the glycoprotein represents only 5% of that. So the amyloid itself could be actually be healthy and could be important for the long-term memory. But amyloidosis is an abnormal and excessive deposition of this protein in between cells. Okay? But the extracellular component is not the only site where the amyloid deposit. So it can come into the extracellular component, and this will lead to compression in the cells, and by compression will lead to malfunction of these cells. However, it can deposit as well into the wall of the blood vessels, and that can lead to even ischemia. Okay, can also deposit in the basement membrane of the glomeruli, and that will lead later on to chronic renal failure. So the amyloid that deposits in patients with chronic infection or chronic inflammation does not resolve at all. So usually we have some two protective mechanisms that can protect us from this folding. Could this usually happen on the cell turnover anyway? So two mechanisms on the outside the cell. So the macrophages will come and unfold this protein back to the normal shape. That's outside the cell. And if it was inside the cell, the proteasome will do that. So unfold it. However, in the amyloid deposit and the chronic infection or chronic inflammation, it will form some sort of aggregate or insoluble material that is very difficult to dissolve by the other two mechanisms. And sometimes those two mechanisms are not actually working. The macrophages and the proteasome are not working. All right? The type of amyloid protein, so we have two different types of amyloid protein, or actually like three different types. So you have something called amyloid associated protein, and amyloid light chain protein, and something called beta 2 microglobin. So associated, which we mentioned it early, so it usually happens in any patient with chronic suppuration. So an abscess can lead to that as well, whether it's a lung abscess or an osteomyelitis or anything like that. It can happen in a granuloma formation, and that happens with the TB. It can happen with some tumors, such as lymphoma, and parasitic infections, such as malaria, and also ulcerative colitis and rheumatoid arthritis. So this is amyloid-associated protein. And again, that will deposit into the extracellular component. Amyloid light chain protein, the cause is completely unknown, but it forms mainly from the plasma cells. That's why the commonest type is multiple myeloma rather than lymphoma. So multiple myeloma. Know here that lymphoma as a tumor is the commonest one, but for amyloid light chain protein, it's multiple myeloma. Beta 2 microglobin on the other side, it will form in patients with chronic renal failure. So that will deposit into the basement membrane, all right, of the glomeruli, the basement membrane of the glomeruli. But the commonest two are amyloid associated protein and amyloid light chain protein. What are the type of amyloidosis in chronic inflammation? We mentioned it will be amyloid associated protein. Histological properties does amyloid exhibit? So there are some sort of two different stains that we can use, and it will be Congo red or apple perfringens, apple green perfringens under plain polarized light. You don't really need to remember that; it's absolutely fine. The clinical findings in amyloidosis, so it can deposit basically anywhere. So if it deposited in the brain, it will lead to Alzheimer's disease or loss of memory or loss of the cognition. If it deposited in the heart, can lead to cardiomyopathy, arrhythmia, heart failure. If it deposited into the lung, will lead to some sort of shortness of breath and all these kind of complications. In the kidney, will lead to renal failure. And the tissue itself, if it's in the tongue, will lead to swelling of this tongue and can lead to malabsorption if it's in the gut and also enlarged liver and spleen. So the classification of the amyloidosis could be systemic amyloidosis and localized amyloidosis. So the localized amyloidosis can have, that, like we mentioned, can happen in the tongue, can happen in the gut, leading to malabsorption. But systemic on the other side could be one of two things, whether it's a primary, so it's not associated with anything, so that will be amyloid light chain protein, or secondary, which is associated with the chronic inflammation or chronic separation or granuloma formation or tumors or also the rheumatoid arthritis and ulcerative colitis. So that would be amyloid associated protein. And the primary is mainly multiple myeloma, as we mentioned earlier. Okay. Could be also related to hemodialysis in chronic renal failure, which is beta 2 microglobin, and could be familial, like familial Mediterranean fever. And the localized, we mentioned all the senility and so on. Well, so the last part of the general pathology is cell death and gangrene. So normally, the cells, our cells, are under continuous turnover, whether it's a programmed turnover, right, or an accidental turnover. So the accidental turnover is when you have a trauma or some sort of inflammation, and we call it necrosis. And the programmed death of cells, because the cells will age and then they will need to die, because otherwise they can mutate and lead to cancer. So we have a program to do that, and it's called apoptosis. So these are the two main programs that our cells die with. So the morphological hallmark of a cell death is basically the nucleus. So if you have a big cell in here with a nucleus inside it, right? With a nucleus inside it, for whatever the reason is. So for example, in necrosis, this cell, let me just take this in the middle. So in necrosis, this cell, this nucleus can start to shrink in size, which is something called pycnosis. And then after shrinking, it will break down into multiple bases, and even further breakdown that is called karyolysis. All right, and this is mainly that organized pathway happen in apoptosis. Yeah, actually, this is a nice diagram. So you do have here the apoptosis. This is the normal cell. Look at the nucleus. It will just shrink inside. So that will be called pycnosis. And then will further break down into small pieces. And that is called karyorrhexis. Okay. And then will be phagocytosed and will be engulfed by the phagocytic cells. So this is apoptosis. On the other side, so if you look at the nucleus, again, it will fragment into multiple pieces. There will be also rupture. This is the mitochondria, rupture to the mitochondria, and release of calcium, rupture of the whole cells, resulting into acute inflammation. All right. So from what you can figure out from here, so necrosis is always pathological, but apoptosis is always physiological. All right. So necrosis is an accidental damage of the cells and is always associated with acute inflammation, and it's almost always pathological as necrosis. Well, the pathogenesis of necrosis, we sort of mentioned it: swelling of the mitochondria, calcium influx, rupture of lysosome and plasma membrane, and death of cells by necrosis. The types of necrosis, there are so many types to cover. We're just going to go through them very quickly. So you have something called coagulative necrosis, and fat necrosis, and liquefactive necrosis, and gangrenous necrosis, and also there are some other types, which are so many really. So for coagulative necrosis, it usually happens in the lung, specifically with infection. Liquefactive necrosis, the tissue will be liquefied, so by the lysosomes as well, and it can happen in brain infarction and abscess and pancreatitis. The gangrenous necrosis is basically the death of tissue, which can either be one of two things, whether it's a wet gangrene, which happens due to venous stasis, or a dry gangrene, which happens due to cutting of the blood supply. Caseous necrosis, which looks like cottage and cheese, and it happens in TB. Fat necrosis typically happen in the breast due to trauma, and saponification, it happens around the pancreas in acute pancreatitis, and that's one of the reasons why the patients in early acute pancreatitis can get hypocalcemia due to release of free fatty acids that will chelate the calcium later on. And also fibrinode necrosis that happens in the wall of the blood vessels in malignant hypertension specifically. The apoptosis, it's a physiological process that leads to death of the cells, and it's called the programmed cell death. And we know the hallmark for it is the nucleus shrinkage or the pycnosis, the nucleus shrinkage, or something called pycnosis. All right? Well, now it's the point to differentiate between a necrosis and an apoptosis as well. So a necrosis, like we said, it's almost always pathological, right? And it's not programmed, it's accidental. And the karyopyknosis is the hallmark for it. And also the cells will be digested and related with acute inflammation. On the other side, the apoptosis is the complete opposite, and the nucleus will be fragmented rather than karyopyknosis. Gangrene is a type of necrosis, or a gangrenous necrosis. It's a type of necrosis that leads to death of tissue due to effect of their blood supply. What is the difference between the dry and wet gangrene? So, the dry gangrene, it usually commonly happens in limbs, and also due to arterial occlusion. And the wet gangrene usually happen in bowel and due to venous stasis rather than arterial occlusion. Moving on to defining the sepsis and the septic shock and the basic principles of management of a sepsis. So it's very important to try to establish the right definition of sepsis. It's one of those things that we think we know the definition for it, but there is local guidelines that we give a specific definition for sepsis. So a sepsis is a life-threatening condition, which happens due to dysregulated host response to infection. So basically, you have a patient who has been infected with certain bacteria, and their body response to this bacteria is dysregulated, and it's very life-threatening with high mortality, right? So it's a dysregulated host response to infection that leads to life-threatening organ dysfunction. The signs will initially be high respiratory rate and low blood pressure and altered consciousness. But what is a shock on the other side? So a shock is acute circulatory failure due to inadequate tissue perfusion causing cellular hypoxia. All right. So basically, the amount of blood that is going to the tissue are inadequate. On the other side, now let's combine it and define what is a septic shock. So basically, it's sepsis and shock as well. All right. So let's define it and break it down. So it's an acute circulatory failure characterized by cellular and metabolic abnormalities and due to inadequate tissue perfusion. And it's not only that, it happened due to sepsis, which is a life-threatening condition due to dysregulated host response to infection. So basically, we're trying to combine the two definitions in a single one. So recognizing a septic patient is very important, and the way we do that, we use the NEWS score. And any patient with NEWS score higher than 5 will be likely to be septic, and we need to examine them urgently. So the NEWS score basically focuses on the blood pressure, the temperature, the pulse, the respiratory rate, and the saturation. All right, and sometimes the GCS as well. The basic principles of managing a septic shock. As we know, that septic shock is a very serious condition with very high mortality in comparing with just sepsis. So that's why to even start treatment on patient with suspicion of sepsis quite early. So the Surviving Sepsis campaign has recommended the concept of care bundles. There is a few things that we need to do in the early hours, in the first 3 hours, and a few things that we need to do in the first 6 hours. So in the first 3 hours, we need to do something called sepsis 6. And the way I remember sepsis 6 is by the word buffalo, but with just one L. So buffalo B, you do the bloods, and you do the urine output, calculate the urine output, and insert a catheter if needed. The F is for fluids, A is for antibiotic, L is for lactate and ABG, and O is for oxygen. Always start this 6 points treatment on any patient that you're suspecting they might have sepsis. The 6-hour bundle, if the patient is not responding to treatment, we need to start them on vasopressors and to keep the mean arterial blood pressure more than 65, and also remeasure lactate to make sure it's not elevated. All right. Thank you. That's the first 4 topics of pathology, talking about some general concepts of pathology, including abscess, inflammation, amyloidosis, and sepsis and septic shock. Thank you very much, and I'm going to continue on the pathology section, hopefully till the end. Thank you.